The issue of prevention and treatment was another aspect of the pandemic that I believe became sort of highly politicized and greed-based. Cheap interventions like vitamin D that might counteract the pro-inflammatory reactions that lead to the cytokine storm were downplayed significantly. So here's a potential mechanism for this. For this particular treatment, SARS-CoV-2 RNA might increase the presence of SARS-CoV-2 single-stranded RNA might increase expression of this transcription factor NF-kappa B, which in turn would lead to the production of certain pro-inflammatory compounds. With vitamin D3, or at least the modified version of it, 125-dihydroxyvitamin D, blocking the production of excess NF-kappa B, resulting in a reduction in these inflammatory mediators. Similarly, there are a variety of other anti-inflammatory drugs like glucocorticoids, dexamethasone, budesonide, and so forth that could block NF-kappa B and other aspects of the pro-inflammatory cascade. By far, I would say that the public health apparatus had placed a great emphasis on antiviral drugs and vaccines. There was a bit of an emphasis on antibody therapy, but it had minimal effectiveness. Obviously, if you create monoclonal antibodies against a specific strain of virus, then once that virus mutates, then the monoclonal therapy would have minimal use. So the antiviral drugs like remdesivir were highly, highly politicized and touted by individuals, even like Dr. Fauci, who came out, which was very unusual, came out in favor of remdesivir before any peer-reviewed studies had even been conducted. So he's basically taking proprietary data from the company that made this stuff and was saying that in good conscience, I have to tout this drug without any peer-reviewed studies. And I have to believe that it had something to do with the fact that remdesivir costs about $3,000 per treatment. Meanwhile, drugs like ivermectin and hydroxychloroquine, which were much maligned and highly politicized, are pennies a treatment. So Paxlovid is also one of these drugs that came out. And again, I mentioned Paxlovid as an anti-protease, so it interferes with the viral protease to prevent it from maturing its polyproteins. Remdesivir is supposed to interfere with the RNA polymerase of the virus. And again, I'll get to vaccines in a minute, but here's a specific emphasis on remdesivir. The drug, it starts off as a prodrug, meaning it's not functional until the cells of our body process it into a more functional form. So it's a nucleotide analog. And in this particular case, the nucleotide analog tricks the RNA-dependent RNA polymerase into grabbing onto it and trying to add it to the growing RNA chain during replication. And again, because it's not built properly, it acts as an inhibitor to block RNA chain extension. And so, but again, as I said, here's an article from Medscape, for example. Large remdesivir study finds no COVID-19 survival benefit with remdesivir. Yet the hospitals were pushing this stuff. And if you talked about remdesivir, you didn't lose your job, or you weren't branded as a misinformation person, or whatever the heck they were saying. And so again, I found that very curious, that a drug, because of its price, really that was the only logical conclusion I could come to, that because it was an expensive drug, they really wanted it to work. As opposed to, say, hydroxychloroquine, which you see here is one of the potential mechanisms. Now, in this context, hydroxychloroquine is not necessarily the antiviral. So hydroxychloroquine is an ionophore in one of its functions, meaning that if you flood the system with zinc and hydroxychloroquine, the zinc can then passage into the cell and then ultimately interfere with different aspects of replication. So here you see zinc ions that are trafficked into the cell through hydroxychloroquine, interfering with the RNA-dependent RNA polymerase, or even the protease. And so here you see zinc on the external surface interfering with that interaction between furin and the spike protein, or even ACE2 and the spike protein. So clinicians that I spoke to in other countries, for example, Brazil, were using hydroxychloroquine with loads of zinc and other drugs as well in combination in order to fight the pandemic, because many poor countries just don't have access to drugs that cost $3,000 a treatment. And even if they did have access, how many of their patients could actually afford it? So again, I really think greed was driving the pandemic in many ways, including treatments. This is another aspect of the pandemic response that, or even messaging, that was very disheartening, was the idea that we're all equally susceptible and there's no natural immunity, so we have to just hide in our houses and order takeout and work from home and wait for a vaccine. And eventually we started branching out and doing the kinds of studies that I'd been calling for since day one, just based on demographics of the people with bad outcomes in COVID, knowing that they were advanced age and like multiple comorbidities and so forth. But it became pretty clear that deliberately infecting young adults, for example, letting them go about their lives, letting them go to school and so forth, was actually quite safe. So here's a little bit about the typical vaccines that were used during the COVID pandemic, or developed anew during the COVID pandemic. One was this non-replicating viral vector vaccine. So that was AstraZeneca, Oxford vaccine in Europe, and then the Johnson & Johnson that we had here in the United States, primarily. So you can see that it's a adenovirus core, basically shell rather, with the with genetic information encoding the coronavirus or SARS CoV2 spike protein. These are, the unfortunate thing is that these were designed for the original wild type SARS CoV2, and so obviously the virus does mutate, although not quickly, but still mutates, and eventually these things lost efficacy. So you see in their trial studies, the clinical trial studies, the efficacy was greater than 90% at preventing serious disease. But as more data came in, the effectiveness, the real world effectiveness, when this was actually injected into arms in the general population in the real world, the effectiveness dropped off significantly. And so here's the virus. These non-replicating viral vector vaccines get injected, and then they're recognized by the immune response, which attacks them. This is very similar to what I showed you in a previous video. Attacks them and then presents their antigens on the surface to the rest of the immune response. One of the great things about these vaccines, though, however, was that they're a single dose, and they only require refrigerator storage, which is huge for countries that don't have access to, -80 freezers, for example. And they're also cheaper. They're, $4 per dose, for example, compared to the Pfizer, BioNTech, and Fauci and NIAID teaming up with Moderna to produce that Moderna vaccine. So that's these here, the RNA vaccines. And basically what they are is a string of RNA that encodes the virus spike protein. And again, the original vaccines were all based on the wild type original SARS-CoV-2. So it wasn't surprising that after a period of time, we went from 94% efficacy in clinical studies to super low effectiveness in the real world studies. Not real world studies, but real world application. So this lipid nanoparticle that encases the RNA facilitates the uptake into muscle cells, for example. And so then the viral proteins are quickly translated. The viral RNA is quickly translated into viral proteins, and then those proteins are then recognized by components of the immune response, which in turn present them to T helper cells, and T helper cells to B cells, as I showed you previously. So again, the other aspect of this, this is 2 doses. They require ultra low freezer temperature, and they're much more expensive per dose. The other component of this that's interesting is you're actually putting a piece of genetic information into the cell. The question is, can this piece of information be reverse transcribed into DNA and enter the nucleus and become more permanent? And there has been some studies to show that, at least in cell culture. The other component to this is that this viral RNA, in order to make it a little bit more stable than a traditional normal RNA that gets degraded very quickly has been engineered to not degrade so fast. So that means that you get viral protein production produced for weeks as opposed to minutes. And again, what is the long-term effect of your cells just producing virus proteins? Are these cytotoxic in and of themselves? So there is some evidence to suggest that they are. Another aspect of the vaccination approaches is that, the injections go here. And the question is, how can that immune response spill over into the rest of the body? And does it spill over effectively? One of the approaches that's often used, especially with respiratory viruses, are these so-called mucosal vaccines. And so this would mean misting live weakened viruses into the respiratory tract directly, usually through the nose. And so the viruses, these weakened viruses, can stimulate localized immunity. You can see these regions here, M cells, for example, and where there's a concentration of immune cells, and these localized immune responses can produce immunoglobulin G, IgA, IgG, for example, and IgA primarily, and coat the mucosa to prevent infection. So these other vaccines that I showed you, the RNA vaccine and the non-replicating viral vector vaccine, turned out to be non-sterilizing, meaning that they didn't prevent transmission, and the best that they could offer was for a certain cohort of individuals to reduce their likelihood of going to a hospital. But for children, for example, and healthy adults, the benefit was not there. It just wasn't there. In fact, it was probably more risk than benefit, even though the risk was very low. So again, the mucosal vaccines could have potentially made a difference. I'm not sure if anybody's really working on them. I know there's a flu mist, for example, as a way to combat influenza. But again, there are logistical issues with generating these types of vaccines. So as I mentioned, there was sort of an unwillingness, a reluctance by people like Dr. Fauci to admit that natural immunity was strong in this infection. I think they were afraid that people were going to be like, oh, I don't want the vaccine because I already had the infection. And that's strange, because that's exactly what should have happened. And eventually, journals like Science came around and started saying, okay, SARS CoV2 infection does confer greater immunity than the vaccines. And even the CDC, changed their tune a bit. Unvaccinated people are more than twice as likely to get COVID reinfection. And then, slowly kind of realizing that there's just a mountain of data supporting natural immunity, started making these sort of backpedaling. Natural immunity is stronger than vaccines alone during the Delta wave. And so, one of their own papers in MMWR really supported that point, and I was really surprised. They simply glossed right over it in the analysis part of the paper. And so here they're showing a estimated hazard rate on the y-axis, and then dates, so you can kind of get a sense for when these data were collected. So here's start of the Delta variant predominance, and basically what you see here is that an individual that's unvaccinated with no previous COVID diagnosis has a higher hazard rate, significantly high hazard rate. But again, they're not necessarily age stratifying these. They're sort of lumping the 90-year-olds in with the 10-year-olds and so forth. So again, these data are a little bit disingenuous. But the point that I wanted to make is down here. This blue line here, hatched blue line, not hatched, broken up blue line, vaccinated, no previous COVID diagnosis, actually has a higher hazard rate than the next line down, which is unvaccinated, but has had previous COVID-19 diagnosis. So what this is clearly showing us is that you're largely protected if you had a previous COVID-19 diagnosis against a reinfection with Delta. And so again, just ignoring these data really was problematic in a lot of ways, because I personally know colleagues that one in particular that ended up being fired from his very prestigious job because he refused to get vaccinated because he had already had COVID and recovered from it. And so the data are right here, and individuals like that are losing their livelihoods over this. Again, not scientific whatsoever. And so if we look at this Lancet data from a Lancet paper, this is past SARS CoV2 infection protection against reinfection, a systematic analysis, systematic review and meta-analysis. So you see the number of studies that each of these bars is based on, and then the particular variant. And so protection against severe disease, if you had Omicron BA1, is about 82%. These numbers are higher than vaccination. The 95% confidence intervals are still higher than vaccination. And so you can see against Delta, if you've had if you had a past SARS CoV2 infection, you're 97.2% protected against Delta. I mean, these are huge numbers, and again, just as big, if not bigger, than the numbers for vaccination. And again, this really runs counter to that phenomenon that was happening, where people were, for example, maligning and belittling people that didn't want to get more vaccine shots, or any at all if they had recovered from COVID. These data clearly show that there was no scientific justification for firing people that didn't want to get subsequent shots after being infected and recovering. And so another aspect of intensive pushes towards vaccination, especially when you've got a single target vaccine based on an ancestral strain of the virus or a wild type strain of the virus, was this concept of evolutionary escape. It's kind of like antibiotic resistance. If you throw a bunch of antibiotics into the system, into the population, it's only a matter of time before you start to develop resistance to that particular antibiotic, which is why, we're trying to limit the amount of antibiotics we use in agriculture, etc. Those are prophylactically used typically. But again, the idea that you have a non-sterilizing immunity produced by these vaccines means that you can still, the virus can still replicate and hyper-select for the buildup of standing populations of virus with the capacity for immune escape. So this is my own personal situation. Just before getting my COVID-19 booster, my Pfizer COVID booster, this again, just before this was my and again, this is just a simple lateral flow assay, but this was my antibody response, still very robust, and basically saying that I had a very robust circulating IgG level, antibody level. So the question is, did I need this? Was this all risk and no reward, given that this was my immune status just prior? This is just days prior to taking this vaccine. And so again, I would argue that no, I didn't need it, but I did it just to not rock the boat. And again, looking at it from a global scale, why does all this matter? What I'm talking about? But here's what UNAIDS said about the COVID vaccination policies. Rich nations are vaccinating one person every second, while the majority of the poorest nations are yet to give a single dose. So here in the United States, we were pushing hard, and I say we, I mean the public health infrastructure, people like Fauci were pushing hard to get these vaccines approved for babies and toddlers and elementary school kids that did not need them. Meanwhile, some 80-year-old in Bangladesh would never even come close to getting their first shot. Again, that's problematic, especially for people who claim to care about the poor and health equity. So if we look at it more specifically, this is from a Nature paper, and this is one graph in that Nature paper, which kind of wasn't really mentioned too much, but what you're seeing here is excess myocarditis events versus the particular condition of the patient. So the AstraZeneca, there was no excess. The AstraZeneca first dose first and second doses. No excess events. Pfizer-BioNTech, a small amount of excess events in first and second dose. And again, these are myocarditis in individuals less than 40. And then here's the Moderna vaccine. And so again, you see a reasonable amount of excess events after the first dose, and then a skyrocketing amount after the second dose compared to natural infection. So the second dose of Moderna is actually significantly increases your risk of myocarditis if you're a low risk individual overall for any downstream bad effects of the virus compared to actually having the virus. And that's, and you start to see why other countries like Sweden decline to recommend vaccines to young kids. We just don't see any clear benefit. So the bottom line is, how does this end? Well, some kind of immunity, and I would say it's a combination of natural and vaccine immunity. Vaccine immunity primarily for the elderly and people with severe comorbidities, but natural immunity for everybody else. And then obviously many of these people were coerced into getting vaccinated, so they're going to have some combination of both. I had both shots, and I also had COVID twice. So I have a combination of natural and vaccine-derived immunity. And there's often this element too, this concept of natural attenuation, where the virus just sort of evolves to become more hospitable to the host. So particularly if you're a respiratory virus, your Darwinian goal should be to keep your patient on his or her feet so that person can continue sharing you in public. If you're such a devastating virus that you knock somebody on the floor and they're in bed isolated, you're not going to be a very successful pathogen. That's why MERS, for example, does not spread for very long once it jumps from camels into people. It burns out quite quickly because it's so devastating. And so, again, natural attenuation seems to be where evolution should put these guys. And that's, again, in 2009, H1N1 was not a major killer in the US. And presumably because a lot of the population had experienced H1N1 at various stages over the past few decades. Will an antiviral come in and save the day? Well, Paxlovid seemed to help older people stay out of the hospital, so it did a little bit, I would say, Paxlovid in particular. But burnout is probably another big one too, where the virus is just out there smoldering, but people are just done with it and resume their lives. And yeah, they get COVID, but they treat it just like they would a bad cold or a flu.